May mali ba?
Pagpunta sa doktor, sabi niya may retinoblastoma si baby. Ano nga ba retinoblastoma?
Ang retinoblastoma ay isang uri ng cancer ng mata na kadalasang nakikita sa mga batang 4 na taong gulang at pababa. Isang tumor o mass ang tumutubo sa loob ng mata ng bata na maaaring makaapekto sa paningin niya at sa kalaunan ay sa itsura ng mga mata. Kung napapansin ninyo na ang anak niyo ay may leukocoria o pagkawala ng red-orange reflex ng mata, dulot ng tumutubong tumor sa loob ng mata, strabismus o pagkabanlag, nystagmus o involuntaryong paggalaw ng mata o pamumula ng mata, agad na magpatingin sa doktor. Kung kayo ay may napansin sa mga sinabi, importanteng pumunta sa espesyalista ng mata o sa isang ophthalmologist upang matulungan ang bata bago lumala ang sakit. Pagkasilang ng bata at bago man lumabas ng ospital, importanteng masilip na agad ng mga doktor ang mata ni baby upang makita kung healthy ang kanyang mata. Importante din na mapa-newborn screening ang anak ninyo lalo na kung may history ng retinoblastoma sa pamilya. Kapag kumpirmado nang may retinoblastoma si baby, maaaring gawin ang chemotherapy upang mapaliit ang tumor ng mata. Iba pang uri ng gamutan para sa retinoblastoma ay ang cryotherapy, laser photoablation, radioactive plaques, at enucleation. Regular din dapat ang check-up para sa pag-monitor ng mga mata ni baby. Kung maagang makikita at maaagapan, ang retinoblastoma ay kayang mapagaling ng walang mga komplikasyon sa paningin. Kaya kung may napansin na sa mga mata ni baby, magpa-check up na. Mas madaling gamutin ang retinoblastoma habang maaga pa.
Sa panahon ngayon, iba na. Ang karaniwang araw ng bawat Juan, Pedro at Maria ay makipagkita na lang sa internet. Pero paano kung biglaang magkasakit si Pedro? Nangangati, may mga butlig at unti-unti nang di makakita. Ano na ang gagawin? Maaaring mayroon ng tinatawag na shingles o kulebra si Pedro. Maliban sa katawan, pwede itong makaapekto sa mukha at mata. Paano nga ba nagkakaroon ng kulebra? Ito ay isang sakit na nadudulot ng isang virus. Itong virus rin ang sanhi ng chickenpox o bulutong tubig sa mga bata. Maski gumaling na ang bulutong tubig, ang virus ay nananatili sa mga ugat o nerves. Sa pag-edad at pagkakasakit, maaaring magising muli ang virus at magdulot na naman ng sakit na tinatawag na shingles o kulebra. Hindi ito tulad ng bulutong tubig na nakikita sa buong katawan. Ang pananakit at putlig-putlig ng kulebra ay nakikita lamang sa isang parte ng katawan. Kapag ang isang tao ay nagkaroon ng kulebra sa may parte ng muka, ay pwede nitong maapektuhan ang ating mata o ang tinatawag na herpes zoster ophthalmicus. Maliban sa mga butlig sa muka, maaaring magkaroon ng lagnat, pananakit ng ulo at mata, pagluluha, pamamaga ng talukap ng mata, at pagiging sensitibo sa ilaw. Sa mga ganitong pagkakataon, maaari nang magsuspetsya ng herpes zoster ophthalmicus. Ano ang iyong gagawin kung may herpes zoster ophthalmicus ka nga? Mainam na kumonsulta agad sa iyong doktor o sa isang espesyalista sa mata upang maagapan ang potensyal na pinsala sa cornea. Ang HZO ay ginagamot gamit ang antivirals. Ang mga ito ay pumupuksa sa mga virus na nagdudulot ng HZO. Maaari rin mabigyan ng steroid para sa mata upang malunasan ang inflammation o pamamaga. Nakakahawa ang kulebra, kaya dapat maagapan ito ng maaga. Mahalagang ma-diagnose ng maaga ang impeksyon upang mapigilan ang pagtuloy nito sa HZO. Mas maganda kung maiwasan ang impeksyon sa pamamagitan ng bakuna laban sa varicella zoster virus. Ginagamit din ang varicella immunoglobulin upang maiwasan ang mga epekto nito kung
Ang paningin ang ating koneksyon sa kapaligiran. Ito ang nagbibigay impormasyon sa atin tungkol sa ating kapaligiran na nagiging basehan ng ating mga aksyon at emosyon. Ang mata ay isa sa mga pinakasensitibong bahagi ng ating katawan, kaya dapat natin ito laging protektahan. Hindi maaaring palitan ng iyong mga mata, kaya mahalagang isaalang-alang ang proteksyon nito sa bawat gawain sa iyong trabaho. Ano ang protective eyewear? Ang protective eyewear ay proteksyon sa mga mata at kung minsan ay sa mukha, gaya ng goggles o face shield na idinisenyo upang maiwasan ang aksidente. Bakit ito mahalaga? May mga trabaho na kinakailangan ng proteksyon sa mata upang maiwasan ang iba't ibang mga aksidente na maaaring makaapekto sa ating mga paningin. Mga halimbawa nito ay ang mga maliliit na butil na maaaring tumalsik sa mata habang naglalagari, nagpupukpok o nagbabarena ng mga kahoy o metal. Bukod sa mga maliliit na bagay na pwedeng tumalsik sa mata, maaari rin itong matalsikan ng mga kemikal. Ang usok din na mula sa pagwe-welding o paghihinang o mula sa mga iba't ibang makina ay maaari ding maging sanhi upang mairita ang mga mata. Kaya naman, importante ang pagsuot ng proteksyon sa mata dahil ito ang pinakamahusay na depensa mula sa mga ocular emergencies. Ano nga ba ang mga klase ng protective eyewear at ano ang nararapat sa sitwasyon? Safety glasses. Safety glasses ay inilalaan upang protektahan ang mga mata ng nagsusuot mula sa mga peligro ng epekto tulad ng paglipad ng mga fragment, bagay, malalaking chips at mga maliliit na butil. Goggles. Goggles naman ay inilalaan upang maprotektahan ang mga mata ng nagsusuot mula sa mga peligro ng epekto tulad ng pagtalsik ng mga maliliit na bagay pati na rin mula sa pagtalsik ng iba't ibang mga kemikal. Ang mga goggles ay umaangkop sa mukha kaagad na pumapalibot sa mga mata at bumubuo ng isang pangharang na selyo sa paligid ng mga mata. Pinipigilan nito ang mga bagay na pumasok sa ilalim o paligid ng mga goggles. Welding helmet o shield. Ito ang angkop gamitin habang naghihinang o welding. Hindi lang nito pinoprotektahan ang mga mata mula sa tumatalsik na maliliit na bagay, kundi pati mula sa usok at nakasisilaw na kislap mula sa welding. Face shield. Ang face shield ay parang goggles din, pero imbes na sa mata lang, ang buong mukha ay protektado sa mga lumilipad na bagay. Ngayon, ginagamit ito pang kontra sa COVID-19 bilang Personal Protective Equipment or PPE para sa mga particles tulad ng virus para hindi umabot sa mukha. Ano ang gagawin kapag ang iyong mata ay nairita o natalsikan ng chemical o natamaan ng mga bagay? Talsik ng chemical. Kung ang iyong mga mata ay natalsikan ng kemikal, dapat nang dumiretso na kayo sa emergency room. Importante ding alalahanin kung anong kemikal yung natalsik sa mata. Kumuha ng malinis na tubig at hugasan ng mga mata ng tuloy-tuloy habang makarating sa pinakamalapit na emergency room. Natamaan ng mga gamit sa trabaho. Kung ang iyong mata ay natamaan o napasukan ng mga maliliit na bagay, importanteng tingnan kung nasugatan ng mata o lumalabo ang paningin ng natamaang mata. Kung nasugatan ng mata o may mga bagay na nakapasok sa loob ng mata, dumiretso na agad sa emergency room. Huwag igagalaw o subukang tanggalin ang nakapasok sa mata dahil may tansya na mas malaki o mas lumala pa ang sugat. Bilang konklusyon, hindi na dapat umabot pa sa ganito. Protektahan ang ating mga mata, magsuot ng tamang proteksyon sa trabaho.
Sa panahon ngayon, iba na. Ang karaniwang araw ng bawat Juan, Pedro at Maria ay makipagkita na lang sa internet. Pero, paano kung biglaang magkasakit si Pedro? Nangangati, may mga butlig at unti-unti nang di makakita. Ano na ang gagawin? Maaaring mayroon ng tinatawag na shingles o kulebra si Pedro. Maliban sa katawan, pwede itong makaapekto sa mukha at mata. Paano nga ba nagkakaroon ng kulebra? Ito ay isang sakit na nadudulot ng isang virus. Itong virus rin ang sanhi ng chickenpox o bulutong tubig sa mga bata. Maski gumaling na ang bulutong tubig, ang virus ay nananatili sa mga ugat o nerves. Sa pag-edad at pagkakasakit, maaaring magising muli ang virus at magdulot na naman ng sakit na tinatawag na shingles o kulebra. Hindi ito tulad ng bulutong tubig na nakikita sa buong katawan. Ang pananakit at putik-putlig ng kulebra ay nakikita lamang sa isang parte ng katawan. Kapag ang isang tao ay nagkaroon ng kulebra sa may parte ng muka, ay pwede nitong maapektuhan ang ating mata o ang tinatawag na herpes zoster ophthalmicus. Maliban sa mga butlig sa muka, maaaring magkaroon ng lagnat, pananakit ng ulo at mata, pagluluha, pamamaga ng talukap ng mata, at pagiging sensitibo sa ilaw. Sa mga ganitong pagkakataon, maaari nang magsuspetsya ng herpes zoster ophthalmicus. Ano ang iyong gagawin kung may herpes zoster ophthalmicus ka nga? Mainam na kumonsulta agad sa iyong doktor o sa isang espesyalista sa mata upang maagapan ang potensyal na pinsala sa cornea. Ang HZO ay ginagamot gamit ang antivirals. Ang mga ito ay pumupuksa sa mga virus na nagdudulot ng HZO. Maaari rin mabigyan ng steroid para sa mata upang malunasan ang inflammation o pamamaga. Nakakahawa ang kulebra, kaya dapat maagapan ito ng maaga. Mahalagang ma-diagnose ng maaga ang impeksyon upang mapigilan ang pagtuloy nito sa HZO. Mas maganda kung maiwasan ang impeksyon sa pamamagitan ng bakuna laban sa varicella zoster virus. Ginagamit din ang varicella immunoglobulin upang maiwasan ang mga epekto nito kung na-expose sa taong may aktibong infeksyon.
Bakit ganito? Pagkuha ng litrato, may puting nakikita sa mata ni baby. Lahat ng litrato niya, ganyan. May mali ba?
Pagpunta sa doktor, sabi niya may retinoblastoma si baby. Ano nga ba retinoblastoma?
Ang retinoblastoma ay isang uri ng cancer ng mata na kadalasang nakikita sa mga batang 4 na taong gulang at pababa. Isang tumor o mass ang tumutubo sa loob ng mata ng bata na maaaring makaapekto sa paningin at sa kalaunan ay sa itsura ng mga mata. Kung napapansin ninyo na ang anak nyo ay may leukocoria o pagkawala ng red-orange reflex ng mata, dulot ng tumutubong tumor sa loob ng mata, strabismus o pagkabanlag, nystagmus o involuntaryong paggalaw ng mata o pamumula ng mata, agad na magpatingin sa doktor. Kung kayo ay may napansin sa mga sinabi, importanteng pumunta sa espesyalista ng mata o sa isang ophthalmologist upang matulungan ang bata bago lumala ang sakit. Pagkasilang ng bata at bago man lumabas ng ospital, importanteng masilip na agad ng mga doktor ang mata ni baby upang makita kung healthy ang kanyang mata. Importante din na mapa-newborn screening ang anak ninyo lalo na kung may history ng retinoblastoma sa pamilya. Kapag kumpirmado ng may retinoblastoma si baby, maaaring gawin ang chemotherapy upang mapaliit ang tumor ng mata. Iba pang uri ng gamutan para sa retinoblastoma ay ang cryotherapy, laser photoablation, radioactive blacks, at enucleation. Regular din dapat ang check-up para sa pag-monitor ng mga mata ni baby. Kung maagang makikita at maaagapan, ang retinoblastoma ay kayang mapagaling ng walang mga komplikasyon sa paningin. Kaya kung may napansin na sa mga mata ni baby, magpa-check up na. Mas madaling gamutin ang retinoblastoma habang maaga pa.
Hi, good afternoon, everyone. Welcome to another episode of EyeTV. I am Emma Echeverria, and joining us today is my co-host, Dr. Pia Texon Diaz.
Hi everyone. Hi Eman, and congratulations on recently passing the PPO exam.
Thank you.
It's great to be hosting another episode of ITV today. We would like to welcome all of you to another look at the lid.
We'll start today's episode with a few words from Dr. Lagunza, the consultant of the Plastic, Lacrimal, and Orbit section of the Medical City Eye and Vision Institute.
Good afternoon. As we try to adjust to the new normal, it is important to continue the process of learning and honing our skills in ophthalmology. We are proud to present to you another episode of TMC ITV entitled Take the Lid, Exploring Eyelid Trauma and Blepharoplasty Complications and Repair. In the next few minutes, we hope to show you the different facets of eyelid surgery. We will discuss different aspects, modifications, and developments from a holistic approach. This includes indications, techniques, as well as common complications in eyelid laceration repair and blepharoplasty. Furthermore, we will tackle important factors to consider in managing our post-op patients and enhancing wound repair. On behalf of the Oculoplastics and Lacrimal section and our Institute Director, Dr. Vic Caparas, I would like to express my gratitude in advance to our speakers and our organizers for putting together this session in one of the most useful and practical topics for discussion. I'm certain that today's episode will bring together the minds of our consultants and our residents. I hope that you find this episode of ITV useful for your continuous desire to improve your craft. Thank you, and may you all have a nice day.
Thank you very much, Dr. Lagunza. So for today, we will be taking all of our viewers on a journey of the lid. So this time, it will be on common post-operative complications. As with all things, prevention is better than cure. We will first start with a review on the basic techniques and repair. So we know our patients are entering or going in for safety and optimal hands of the Then later on, we will tackle some post-operative problems for lid diameter, blepharoplasty, and avoid.
For all trainees and those beginning their practice, I think this will be very helpful. Today we'll be introducing these topics with cases from our speakers to be able to see theoretical concepts applied in actual trauma. Allow me to introduce our first speaker, Dr. Rian Parulan. Dr. Rian is a graduate of the Ateneo School of Medicine and Public Health. She then trained at the Quirino Memorial Medical Center for her opta residency and did her fellowship training in ophthalmic, plastic, and reconstructive surgery at the National University Hospital, Singapore. She's currently a PLO consultant at QMMC and the Medical City.
So we also have joining us today our very own Dr. Pastor Rosete. So Dr. Pastor Rosete graduated medicine at the University Ramon Magsaysay Memorial Medical Center and finished her ophthalmology residency at the Medical City, where she also served as a chief resident. She then finished her fellowship in Orbit, Ophthalmic, Plastic, and Reconstructive Surgery at Shiley Eye Center, La Jolla, California, USA. Currently, Dr. is an affiliate at the Eyesight Vision Center and an active consultant at the Medical City, East Avenue Medical Center, and Providence Hospital. So as always, if you have any questions Drop it in our chat box and kindly wait till the end of the episode for them to be answered. So without further ado, Dr. Ian, the floor is now yours.
Hi. Hello? Can everybody hear me? Hello? Ayan. Okay. Good afternoon, everybody. Thank you, Pia and Eman, for that very kind introduction. So, to start off this afternoon, I am tasked to discuss with you this topic, which is an important aspect of optimizing eyelid trauma repairs and reconstructive surgeries that we may sometimes admittedly overlook. So I have no financial disclosures, and this will be the outline for this discussion. So first, allow me to take you back to the basics and discuss with you the normal process of wound healing. As you recall from med school days, the first process of wound healing occurs from day 1 through day 5 is inflammation. So hemostasis occurs in seconds to minutes, mediated by the release of prostaglandins and thromboxane. Your platelets rush into the site of injury where adhesion and aggregation occur to initiate clot formation. So this then, the intrinsic portion of the coagulation cascade is activated, which then produces this fibrin platelet matrix to control bleeding and will later on act as a scaffold for wound healing. So this is comprised of your collagen, your fibronectin, your thrombin, and your platelets. So from day 3 to 5, your inflammation ensues. And as a byproduct, vasodilation and capillary permeability occurs and will clinically present as your edema. So this is actually what we tell our patients when we do surgeries on them, that 2 to 3 days later, they expect more swelling. So two key players during this phase would be your neutrophils, and they are attracted to the injured zone to phagocytize debris and bacteria. They further release free radicals to kill these pathogens, and they activate complement fragments to further sterilize the wound. Now, the second key players would be your macrophages. So initially, they are your monocytes that get attracted to wound sites and become activated. Although they have some phagocytic role, they are responsible as well for initiating transition from inflammation to proliferation. So this mediates angiogenesis and wound healing through the synthesis of different growth factors such as the following. Your proliferation phase occurs from day 4 to 14. Your reepithelialization actually occurs soon after injury with the secretion of your EGF and EGF alpha by your macrophages and platelets from the inflammatory phase. So during this phase, epithelial migration and thickening occurs, and the predominant cell types that are important would be your fibroblasts, which actually synthesize the growth factors to stimulate epithelial migration and proliferation. So in further healing the epithelial layer, the fibroblasts also secretes immature and disorganized collagen type 3 for the provisional matrix and collagen type 4 to form your basement membrane. Your endothelial cells are also important. So remember, in a hypoxic state, VEGFs are secreted to stimulate capillary formation. This ensures growth and survival of new tissues by ensuring adequate blood supply. Granulation formation also describes proliferation phase. So it should appear as your beefy red appearance because of its dense population of vessels, macrophages, and fibroblasts. So for those who've seen orbital extenderation with secondary healing, this is actually the kind of tissue you want to see. So this is important because this indicates health and the overall ability of your wound to heal. With healing by second intention, some fibroblasts are stimulated to become myofibroblasts, which allow the wound to contract. So this then decreases the workload for repair because there's only a smaller area that needs to heal. Finally, the last phase, which is from day 14 up to about a year, your remodeling phase happens. And this last phase of wound healing is focused on quality control and refining the new tissue formed. So this is actually important with scar formation. The key concept here is quality scar formation through a fine balance of ECM degradation, synthesis, and deposition. So remember, in the previous phase, the goal was to close the wound and stop further damage. And at that time, matrix deposition was done in a very haphazard manner. Remodeling in the initial phase just produces immature type 3 collagen, which is now replaced by stronger type 1 collagen. The initial thin fibers deposited are now being replaced by thicker fibrils. So remember that reorganization and cross-linking are needed to create a sound lattice, which will form your mature and hopefully aesthetically pleasing scar. So what are the key players? So this includes your MMPs that degrade ECM components, your fibroblasts which continue to synthesize collagen, your TIMPs which act as a check and balance, suppressing your MMPs degradation activity, and your other cytokines and growth factors that have an influence in the balance of deposition and degradation cycles. Although wound healing is desirable, when signals of repair are ineffective or go haywire, excessive repair may occur, and this results in your pathologic scar. So this is actually the common enemy of us surgeons. These include your hypertrophic and your keloid scars. So your hypertrophic scars are those that don't go beyond the original boundaries of your scar, and it can fade in time. And it's actually one that is easier to manage versus your keloids, which grow beyond the original scar, and they actually have this tumor-like appearance. Some patients will have a genetic predisposition, and remember, surgical excision may lead to recurrence. So actually, this one is more difficult to manage. That's why it's actually a target of different clinical and therapeutic trials. Now, what are the factors that can alter or complicate the process of healing? Are there ways we can prognosticate, predict, or intervene? So the first is bacterial infection. This actually doesn't need much explanation, but to expound further, bacteria impairs fibroblast proliferation, which then decreases your ECM synthesis and deposition, and consequently inhibits wound healing. Your wound infection alters hemostasis and delays granulation formation. So when we do primary repair of these wounds, this is the reason why we maintain good sterility. So to counter infection, we do adequate cleaning and debridement, and we give our prophylactic antibiotics or even tetanus shots. Adequate protein, which we get from our diet or nutrition, is necessary for ECM deposition, especially with increased protein turnover. So these are actually the building blocks of scar tissue formation. But also note that carbohydrates is equally as important because this acts as a fuel for a lot of bodily mechanisms, and that includes wound healing. So other nutrients include the following. So your vitamin C assists transporting collagen to the wound site. It's important in collagen synthesis and scar formation, and the recommended dietary allowance for this is usually 60 milligrams. On the other hand, vitamin A, it stimulates epidermal turnover and increases rate of reepithelialization. It has some effect on reversal of impaired healing in chronic steroid users. But remember, when deciding to give this, do note that this is fat soluble and overdose may occur. So it's important that you know the recommended daily dose for this, which is approximately 25,000 international units. You can give this about during the pre-op phase up to 4 days post-operatively. Vitamin B6 is utilized for collagen cross-linking in the remodeling phase. As you recall, that's important in scar formation. Other key micronutrients would include zinc and magnesium. However, there's still no clear evidence for supplementation in non-deficient patients. So actually, we can assess for patients' nutritional status with a detailed history. So we can check for diet, for geographic location, because some areas have predispositions to some deficiencies. For those we have suspicion for poor nutritional status, we can actually request for albumin or pre-albumin levels. And we can also decide to give supplements for those who have risk factors for poor wound healing. So among systemic factors that are known to affect wound healing are those with arterial occlusions and diabetes mellitus. I'd like to expound a little more on diabetes, which is very prevalent and which most of us or some of us might tend to overlook the impact in wound repair. So this metabolic condition puts the patient in a state of deficient growth factors and cytokines. They have decreased angiogenesis, endothelial dysfunction, and abnormalities in fibroblast function and extracellular matrix. The good news, however, is that this can be improved as long as the patient gets to achieve that better or good glycemic control. Inflammatory conditions that require chronic steroid use also have an inhibitory effect in wound healing, along with its anti-inflammatory effects. Radiation also compromises wounds because of its damage to DNA and its release of free radicals. So what can we do? So the best really for diabetics is to get good sugar controls. Also, we want good BP control. And then for radiation, best we can do is to discuss with our radiation oncologist regarding limiting the extent of radiation damage to tissue without compromising its therapeutic gains. So smoking. So this may sound trivial, but actually this plays a very huge role in wound repair. Nicotine in cigarette acts as a vasoconstrictor, resulting in local ischemia. So it's said that one cigarette stick is equivalent to 40% decrease in blood flow velocity. So it also increases risk of thrombus formation, further decreasing blood delivery to tissues. It also has an inhibitory effect on proliferation of erythrocytes, fibroblasts, and macrophages. But similar to blood sugar control, smoking cessation will still improve wound healing. So what can we do for our patients? We can educate them and encourage them to stop smoking. Although for those who have difficulty quitting, although there's no absolute clear guidelines, if they will be subjected to surgery, you can recommend abstinence with an interval of 4 weeks before and 4 weeks after the reconstructive surgery. So just a few things on what's out there in literature on wound healing. Introduced in 1998, Blepharoplasty was the first FDA-approved topical recombinant growth factor product used to induce growth of soft tissue granulation. So studies on efficacy is mostly aimed at non-healing wounds or those with non-ischemic type of ulcers in diabetics. Another of which are your autologous platelet gels. So now we have devices that is able to process your own blood or your autologous blood to concentrate platelet-rich plasma in autologous platelet gels. So this is actually a combination of your growth factors and are said to have synergistic effect in wound healing. Like in your Blepharoplasty, studies done are aimed on chronic non-healing wounds, and data is still lacking on its potential ability to accelerate normal healing wounds to heal faster. So although more data is needed, studies agree that growth factors still hold promising therapeutic benefits, especially if used as adjunctive therapy in wound healing. Another one is your FDA-approved bioengineered skin products that are available to cover partial and full thickness wounds. So its application in the periorbital area might be limited for now, but at least we know that this is one of the advances in the field that may be helpful, especially for large defects like burns and complex traumatic soft tissue injuries. So in this table, you can see that different products have different compositions and different approved clinical use. VAC or vacuum-assisted device is a technology for wound healing that induces production of granulation tissue. So this is actually another option, especially in complex soft tissue trauma. So as shown in this photo to the left, this involves a mechanical device that decreases air pressure on the wound by connecting the dressing to a vacuum pump. The purpose of this is to remove unwanted fluid wound, decrease edema, increase production of granulation tissue, and decrease bacterial counts. So looking at the setup, one of its limitation, however, is its use in wounds around the eyes, the ears, or over mobile areas because the vacuum seal might be difficult to attain. In this patient, it's quite difficult as well to examine the eye during wound healing. And finally, an update on something more practical that probably anyone who has repaired or treated wound has experience with. So among topical therapies for scar care, silicone gels is probably one of the most popular and one that has shown effective outcomes even in literature. So silicone-based product acts as first-line treatment in most scar management and prevention strategies. It comes in two preparations. It has silicone gels and silicone sheets. So these are the proposed mechanisms on how it works. Understand that it's very difficult or challenging to study the effects of topical regimens in scar formation. But this meta-analysis has shown that silicone-based products is an effective treatment for scar prevention. There is evidence that showed reduction in pigmentation, height, and pliability of scars. They did note, however, that 2 months of application might not be enough and that efficacy may only be significant until 6 months after surgery. So because of the relatively good safety profile, starting patients on this regimen as early as removing sutures can actually help prevent pathologic scar formation, especially for patients with known risk. So in summary, we were able to emphasize that in order to achieve aesthetically appealing wounds and prevent pathologic scars, it's necessary to understand the basics of normal wound healing. To further optimize outcomes of our repairs and surgeries, other patient factors should be taken into consideration. And lastly, we are very fortunate to be in the age of fast-paced technology. The numerous advancements in the field of wound healing, like tissue regeneration, is very promising, especially for our patients with significant defects and large tissue loss. So it's really exciting times for wound healing. So these are my references, and that ends my discussion.
Hi ma'am, you can share na po your
Okay.
presentation.
Good afternoon, everyone. I'm back at the EyeTV again. Nice to be here again. So we're going to talk about basic lid trauma repair, the pearls and pitfalls. I have some references, and most of them are patients I've seen in the clinic itself. So let's get this going. Eyelid trauma are usually lacerations referring to partial or full thickness defects in the eyelid. Most often, they are subsets of facial injuries and with other associated ocular injuries. General mechanisms would be when you get in contact with sharp objects, there would be penetration of superficial or deeper structures, lacerations in itself. Contact with blunt objects would result to avulsion injuries. So our agenda for this afternoon is basically to show in this.
Ma'am, sorry.
Yeah.
I think the presentation isn't showing properly, but we
Hold
just
on.
see uh, the file lang po.
I'll share it again.
Yes po ma'am.
Is it okay now?
We don't see the presenter view po. The
Hold on.
slides.
I have it in presenter view. Hold on.
If, full screen na lang ma'am.
Ayan, it's in full screen already. Hold on. How is it?
Not yet ma'am. We don't see the presenter. You can go full screen after sharing na lang po.
I did. Actually, that's what. Hold on, huh? I am not on full screen now. I'm sharing the screen and now I'm presenting it in full screen. Can you see it now?
No ma'am, sorry.
I don't
We're
know what's
seeing
wrong. Hold
the
on, huh?
PowerPoint. Share the entire screen na lang ma'am. Or maybe it's on another desktop.
How about now?
Yes, ma'am. There we go po.
Better? So
Yes po.
I start from the top?
Just where you left off na lang po, ma'am.
Okay. So we were discussing the agenda for this afternoon. Let me go back to that again. So we are here to show and discuss some common repair techniques for the general ophthalmologists and discuss some complications in repair, basically how to address them. So the eyelid is the outermost protection of the eye. Reflex closure happens before most injuries, and this is observed by cranial nerve 7. So only professional fighters like boxers have actually the training to resist closing their eyes as threat approaches one's face. So it couldn't be further emphasized that sound knowledge of eyelid anatomy and physiology is imperative for effective management of trauma. For one, trauma situations are not predictable. Each case is different, and the surgeon doesn't have the luxury of planned incision. So personally, I say a prayer every time I get a trauma. I always pray to be worthy of the case at hand. So upon referral, I have the following considerations. I usually ask the residents, is it lid margin or non-lid margin? Because the approach and the materials to use would be different, totally different. Is there a canalicular affectation, or is it involved? Because there will be a need for stents and other specialized instruments like canalicular stents or probably a pigtail probe. And definitely, I would ask if there is globe rupture or not. Although for the purpose of this lecture, we will not be discussing on globe ruptures. All this go without saying that systemic stabilization has been established. Our priority has always been life before limb, and the timing of repair has to be decided on. A considerable delay is acceptable rather than having primary repair, which would definitely need more repair than the previous one. So there's also a need for, likewise, need for a check on whether there'll be necessary to have additional diagnostics and medications like tetanus or anti-rabies. So for general wound treatment, I usually do a sharp debridement with blade 15, saline wash, and peroxide, because for me, the peroxide is always helpful with the hemostasis. The initial wash would let me orient myself to the structures at hand, and some may not be identifiable at the onset since it's trauma. Foreign body cannot be missed, so it has to be something that you look for. And you always check for the depth of injury. So for non-lid margin lacerations, this is basically easy to repair already. So usually it's just a direct closure. The depth of laceration is important to inspect, as I said. As it is necessary to repair, make sure not to, as it is easy to repair, make sure not to do more harm. Example, for this photo, it seems easy enough to just close. But it is important to note that there is fat here. So the presence of fat usually signals a breach on the septum, and thus probable levator damage is involved. So let me show you this case, a simple non-lid margin laceration referred to me 2 days post-repair. Patient wasn't able to fully close or open his eyes. Repair done was very tight, and it appeared to be strangulating the skin and the other eyelid structures. So for this one, I had to remove all the tight sutures, explore and release the tissues, reapproximate the skin edges, and then close it up with simple interrupted sutures, using very small bites, 1 millimeter from the skin edge, and using a non-absorbing smallest suture like a Prolene 6 or 7.0. And with this meticulous closure, I avoid tightly tying sutures to the skin. So compared to the first repair, patient was able to open his eyes better, the tissue, and close it as well. The tissues were no longer strangulated, and actually, with just 2 days post first repair, the suture tracks are already very evident, even as I released it. So it is something that you have to take note of. So next case would be this patient. It's still non-lid margin, but slightly more problematic than the first. This is a 4-year-old female playing, and I think in the shower room, the whole glass sliding door fell on her. So thus this injury. So the key for this repair is a generous undermining to advance the flap and repair the laceration. 3 months later, as you can see on the right lower bottom, the left upper lid is already free of any, parang walang nangyari. It's like injury-free. So okay naman siya. She can open and close the eye with very cosmetically acceptable scars. Pero on this one, she had periorbital contusion hematoma on the right kasi medyo malikot talaga yung kid. So this is fortunate because age may work for or against the surgeon, because with revved up growth factors, scarring in children actually may sometimes be unpredictable. Case in point, in this other pediatric patient, a teenager figured in the vehicular accident incurring non-margin avulsion. These were very deep wounds on initial debrima. With generous undermining, I proceeded to use plicating sutures using Vicryl 5.0 for better hold. This was like a mini chick lift, as the goal is to fixate inner structures and remove all tension from the skin. Skin was closed with non-absorbable 6.0 proline. There is much tension underneath actually here. I even had to put a temporary lateral torsorrhaphy to assist the tension around the periocular area. Because of this tension, it is notable that after removal of sutures on the right photo, there are some small areas of dehiscence, but generally forgivable results. Some weeks post-repair, we note the severe hyperemia on the hypertrophic scar starting to develop. The revved up growth factors we were talking about. Even his arms were not spared. So for him, options for treatment at this point were observation, because scar redness will eventually lessen in time. It's important to instruct them, though, not to get exposed to the sun, as this will allow for bad pigmentation to occur. Other options were compressive dressing, use of silicone gel or sheets. I had one session of steroid injection on this patient, but the pain of the steroid may have been prohibitive for him, or the scar probably improved in time, and I lost him to follow up. On hindsight, if I were given the same armamentarium of gadgets and stuff to use, I would have probably used silicone gel sheets at the onset, or probably even use Botox to release tension around the area. So this one is a referral, and I never saw the original avulsion injury. The surgeon was able to put back the avulsed flap, but as you can see, the patient developed bad scarring. This is called a trapdoor deformity or a pincushion defect. They say that from literature, they say that this is due to insufficient undermining or unequal flap thickness with the depth of the recipient site. And this usually occurs within 3 months post-op. So the scar underneath the flap contracts concentrically, thus creating the bulge like a pincushion. So options for treatment would be triamcinolone injection, which I did, usually within 4 to 6 months interval. This can be done for a number of times, but non-resolution in 8 months warrants a scar revision. This is noteworthy to think of because indeed, they sometimes disappear and they get better. But it usually takes a lot of patience because like for this one, pangit talaga tignan yung pincushion effect. But for you to do and dive into another surgery may not be wise, especially if literature dictates you that it may just improve in 8 months' time. So as I said, I gave her steroid injection. I don't know if you can appreciate it from the photo, but there was softening of the edges of the scar after the first injection session. And she reported improvement, though she was again lost to follow up. For this one, this is a trauma to a senior thrown off from a tricycle, incurring severe lid margin injuries. While this one is another lid margin laceration due to dog bites to the face to a dentist. So there's a need to assess for extent depth of damage. If delay of repair is necessary, you should be able to keep the area moist and the eyes lubricated. And it's imperative to check for canalicular damage with medial lacerations. You should, probably all of us have that routine, or we develop a routine in examination. So basically with me, I check the periocular structures and look at the contour or the continuity of the eyelid margin and see if there are any things that I shouldn't be seeing there or things that should be there and are not actually there. So lid margin repair starts off by reapproximating the edges of the margin, gray line to gray line, then lash line to lash line. So do not tie them first and keep the silk sutures long. Unlike other laceration repair or other repairs that you have to do wherein you start deep, with lid margin repair, you start superficially. You don't close the inner unless you have reapproximated the outer, because it's the important part here is to reapproximate the lid and the tarsus has to be aligned. So once aligned, do the partial thickness interrupted Vicryl 6O sutures on the tarsal plate. This is to restore integrity and avoid kinking later on. Add more marginal sutures and tie permanently, making sure the edges are everted to avoid notching on the margin. Suture the skin with Prolene. So the dog bite injury healed pretty well. She had thyroid orbitopathy, so forgive a bit of proptosis, but basically the lid margin's good. I had to repair the cheek and lip laceration as well, as I was not in the hospital setting when I was fixing her, and they healed pretty well. The senior likewise improved, so without really bad ocular injuries inside. He was lucky enough. So what happens when we don't repair a lid margin laceration? So this is another senior, another case, who had a vehicular accident. This is, she had contusion hematoma, sought no consult, and everything was okay except for a foreign body sensation which persisted after the trauma or after the accident. Months later, she sought consult at TMC OPD, and this is what we saw. Lid notching causing inward turning of the lashes on that area. Eman, our host, actually did this case, for which I proposed we do a pentagonal wedge, excise the notch margin and its lashes, and then reconstruct. Patient was quite happy after that. So canalicular injury should be checked always in lid trauma, especially with medial involvement. We should avert lids and inspect, identify the punctum, and insert the probe to check for blocks. So we dilate both puncta, identify the cut ends, and we may insert a stent to approximate the ends and restore the integrity of the canal. Anastomose cut edges with Vicryl 6O suture, and only after then can we make sure that when the canaliculus has been restored, can one proceed to repair the rest of the lids. These are the stents that we may use. On the left, the monocanalicular stent, which made life easier for the rest of us surgeons who deals with this kind of trauma, as this is very easy to insert and remove. Bicanalicular stent remains very useful as well. For trauma, I usually keep my stent for 6 months before removal. On this note, in the agenda, I think we're able to share the basics on the trauma repair and show a glimpse of the common complications to expect and what to do with them. This was done with the purpose that any ophthalmologist can repair with confidence eyelid trauma without causing additional harm or complication to the patient, as with the photo shown in the last slide, which I think there was, the lower lid was sutured to the cheek skin. When lost, always remember to go from the known to the unknown, so do no further harm. And when overwhelmed, just pause, and by then you'll know if you will repair or just refer. Thank you.
Thank you very much, Dr. Parula and Dr. Pasco Rosete, for the in-depth presentation and cases. It's actually very helpful to review the topics as we see them in real practice.
Yeah, that's true. We will definitely be sure to apply everything we're learning here today. So now to tackle the lid even further, it is my pleasure to introduce Dr. Alfonso Bengzon, a consultant at the Eye and Vision Institute of the Medical City. He graduated medicine at the University of the East Ramon Magsaysay Memorial Medical Center and finished his ophthalmology residency at the Makati Medical Center, where he served as chief resident. He pursued and completed his fellowship in oculoplastic, lacrimal, orbital, and reconstructive surgery at the following institutions: at Edward S. Harkness Eye Institute in Columbia Presbyterian Medical Center, New York, USA, at the University of Hawaii Camara Eye Clinic, and at St. Francis Medical Center, Hawaii. So currently, he's an active consultant at the Medical City, at Makati Medical Center, American Eye Center, Asian Hospital, and Asian Hospital Medical Center. So again, let us all welcome Dr. Wengson.
Hello. Um, can you hear me?
Yes, sir. We can hear you and see the presentation, sir.
Thank you. First of all, I wanna sort of I apologize. I have to correct that must be an old data. I'm not affiliated anymore with Makati Med or Asian Eye. I'm just affiliated with the Medical City and American Eye Center. I'd like to thank the organizers and Eye and Vision Institute for inviting me and allowing me to participate. And I'd like to thank everybody who's watching now. Special shout out to my friends and colleagues in the PSOPRS who are watching as well. So my presentation today would be on the complications of blepharoplasty, which is actually a very broad topic and it's difficult to cover everything in the limited amount of time. So the organizers and I decided just to focus on a subsection of complications, those relating to the sequelae of incomplete preoperative evaluation. Blepharoplastic complications can have several sources. You could have complications related to surgical technique where you might have chosen maybe the wrong technique to use for a particular case, or one of the steps in your surgical technique sort of did go as planned. That turns out to be a complication. You could have complications from post-op care, such as a hematoma or an infection. And you could have complications from that come about because of a preoperative evaluation, which was less than ideal. And it's the last part or the last category that we'll handle for today. I'll be showing a couple of cases just to illustrate this. Okay, so let's jump right into it. This is the first case. It's a 52-year-old male. Came in with a complaint of lower eye bags and really deep wrinkles, as this photo illustrates quite clearly. So he underwent evaluation and it was decided that he'd have an upper and lower blepharoplasty. And a week later, this was the result. And you can see, I mean, this picture says it all. The patient developed ectropion post-operatively. And this is a week after, so there's still a lot of swelling and the sutures were removed. But obviously a patient like this would not be happy with this result, understandably so. Such is the same with this next case, which was about a case that was referred to me after 3 months after the blepharoplasty was done. So the diagnosis is quite simple, it's quite straightforward, but more importantly, what happened? It's what you should ask yourself. What happened and how do you repair it? So what happened was essentially probably during the pre-op evaluation, the laxity of the lids was not identified or revealed. So when you do a pre-operative evaluation of lower lids, first you check the lid resting position for any obvious malpositions like ectropion, entropion, attraction, etc. Then you assess how much skin laxity there is so that you can estimate how much skin you'll be removing. And lastly, which is where in these cases, I think where the shortcoming came from, was the determination of how lax is the lid. In a lower bleph, you want to tighten the skin and pull it upwards, but in order to do that, you have to have a lid that's strong enough to hold up that skin. And if there's lid laxity, instead of the skin being pulled upward, the whole lid will be pulled downward, causing the ectropion. So the three tests that are most commonly done to determine lid laxity, just to review: distraction test, snapback test, and the medial laxity test. A distraction test is simply pinching the lower eyelid and pulling it away from the globe and then measuring. And normal would be within 6 millimeters. So anything under 6 millimeters is considered normal without laxity. And anything over that would be a sign of laxity in the eyelid, which should give you a warning. The snapback test, I'm sure everybody knows how to do this, but just to review, same thing, you pull the eyelid away from the globe, release it, and then you count the number of seconds it takes for the eyelid to go back into the normal position, instructing the patient not to blink or move their eye. And you grade it in this fashion, depending on the number of seconds it takes to return. So, and then the medial laxity test is important because you want to find out if there's laxity, where is the laxity? Is it medial or lateral? Because that also plays a part in the kind of surgical plan that you have. So you grasp the lid, pull it laterally, and take note how far the punctum is being stretched. And you grade it in this fashion. So in this case, you can see the punctum quite near the pupil already. So it would be a sort of a grade 3, between 3 and 4 in that particular case, which is quite a lax medial canthal tendon. So once you determine laxity of the lid and you're planning to do your blepharoplasty, you have to do some preventive measures. You have to tighten up that lid so that it's strong enough to hold up the skin, the stretched out skin of the lower lid that you're stretching out. So you do this. There are a couple of procedures you can do. First is a lateral tarsal strip procedure, and the second is a wedge resection. Again, depending on where the laxity is. I use the lateral tarsal strip when you have lateral laxity and the medial laxity of the lid is not severe, or there's no medial laxity. And I use the wedge resection when there's a little bit of medial tendon laxity, so that the stretching of the strengthening of the lid is equally dispersed medially and laterally. So the choice depends on your results of your examination as well. So I just want to show a short video. It's about a 4-minute video on lateral tarsal strip procedure. It just shows like basic steps. So you make your lower lid incision first to start your blepharoplasty. And in this part, we are disinserting the lateral canthal tendon from its insertion, right? This procedure is being done using a CO2 laser. Once you've released it and start dissecting and releasing the lower lid retractors laterally, it allows you to mobilize the lid. And once you've got enough mobility, you can determine or estimate where you want to create your new tarsal strip. So basically what you're doing is removing the skin and orbicularis, the pretarsal orbicularis, because you want to remove all the soft tissue surrounding the tarsal plate in that area. Just leaving the tarsal plate, which is your new tendon. That's the new tendon for your lower lid. So using the CO2 laser, I'm just trimming the orbicularis, exposing just the bare sclera, removing as well the lid margin skin as well as the lashes. Sure. And then in this step, removing the conjunctiva posteriorly to the lid. Okay. So all of this can be done using the CO2 laser. And as you can see, it's quite efficient and quick to do. Because as you're removing tissue, you're also achieving hemostasis. Right. Okay. So just cleaning up the excess, removing some of the fat that's peeking through inferiorly. And after this step, the next step is to prepare the site where you're going to insert the new tendon. So the insertion site is the lateral orbital rim. So I'm doing a sharp and blunt dissection, going inferiorly and posteriorly, locating the lateral orbital rim, making sure that I expose the periosteum, which is where you're going to attach your suture. This is a Prolene 5-0 suture. I'm biting into the periosteum of the orbital rim right now. And then biting into the newly formed lateral tarsal strip that we've created. Okay. And then knotting it just to secure it. Care has to be taken not to knot this too tightly, because if you tighten it too much, that might cause the lower lid to actually go under the globe, which you don't want it to do. The next step would be to close the canthal angle using silk 6-0 sutures. So in the same way that you'd repair a lid laceration, a lid margin laceration, you just connect gray line to gray line and lash line to lash line with the silk 6-0. In this part, we're determining how much skin to remove. This is the last step of the procedure, where once you've tightened up the lid, that's when you can determine what is the correct amount of skin to remove for the last part of the blepharoplasty. And then you just close it as you normally would at the incision site. Okay. So in this case, this patient was supposed to be repaired actually about 4 to 5 months after the surgery, when the swelling was going to be gone. But when he returned, this is what he looked like. So there was no surgical intervention, and it just sort of resolved by itself. I was quite surprised. I was expecting maybe the left lower lid to resolve by itself. I was expecting that I'd have to repair the right at the very least. But upon his follow-up, he was satisfied with the result. He did not wish to have any more surgery to tighten the lid as well. On the other hand, the other patient who was referred to me 3 months after his surgery, that didn't resolve by itself. So we ended up doing a wedge resection for him, and this was the result with that case. Okay, so the next case, 75-year-old, her chief complaint was drooping of upper lids, difficulty reading and watching TV. It's not a cosmetic problem. She was, a real, actual functional problem. And she was determined to have ptosis as well as dermatopalagia. And an upper bleph with, I believe, a fasanella was done for her. And post-operatively, this is what happened. So you see a little bit of increase in the size of the eyes from here to here. However, as you can see, the skin is still drooping. So it's sort of like a before and before picture. There doesn't seem to be a big change in the post-op, which is unfortunate because that was not the goal. So the first question you ask is, what happened here? Why did this happen? Why was there no improvement on the dermatopalagia? And again, I believe it's related to a pre-op evaluation, which sort of missed out something, which is the brow ptosis. If you look at the first picture, you'll observe that the right brow is much lower than the left. And the normal brow position should be above or at the superior orbital rim. And in this case, definitely both eyebrows were lower than the normal position, which sort of makes the dermatopalagia even worse. So if you miss that, and you do, even if you do the ptosis surgery, it still doesn't resolve the dermatopalagia. Patient will still have some difficulty or the same complaint that she came in with. So it's very important not to just focus on the eyes and eyelids, but look at the entire face, up to the forehead, up to the brows, when you're doing your pre-op evaluation. Something like that is quite obvious. Something like this is not so obvious, where you have the patient complaining simply of a lid crease asymmetry, but not realizing that she has a drooping brow. So as you can see, the lid crease on the left upper lid seems to be higher than the right. But upon closer inspection, you'll notice that the right brow is also lower than the left, which makes the drooping skin even more pronounced. So for cases like this where the brow is only slightly ptotic, unlike the first case where a direct brow lift would probably be warranted, or even a forehead lift would be the choice of surgery. In this case, you want to just lift the brow just a little bit and also fixate it. The second purpose for doing a brow surgery is also to strengthen the brow so that it doesn't droop when you remove the skin on your upper lid blepharoplasty. It doesn't end up pulling the brow further down, which is what happened in the first case that we showed you. So a possible surgical repair or preventive measure in this case would be a brow pexy. So let me just show you a quick video on how this is done. So using again the laser, we're removing the skin muscle flap to begin the upper lid blepharoplasty. Once this is done, we could start dissecting laterally and upward. Let me just point out here that there are pre-marked areas on the brow. You can see them on the brow. That's important. I'm pointing it out there. I'm doing a sharp and blunt dissection in the plane above the frontalis bone, and make sure you dissect all the way up towards the brow. And then this is a Prolene 5-0 suture, which I am passing through the brow and pulling it out from inside. And then noting where the suture comes out, you take a bite in exactly that area. So you've bitten right under the brow, not too near the skin, or else we have a dimple on the skin. And then fix that or bite into the periostrum of the frontal bone above the orbital rim. Now, depending on what area of the brow you want to lift, you either sorry, let me take that up. You either do one suture or up to 3 sutures, depending on which area of the brow you need to lift or fix or strengthen. I think in this case we did 2 sutures. So this is the second suture. Same thing, go through the brow, pull out the needle from inside, and then bite into the periosteum of the frontal bone above the orbital rim, and then just close the wound as is. So this is before and after of that patient. You can see that the brows are more symmetrical now, and the lid creases are also approximately closer to each other than they were before. Okay, so I think that's the last. So the takeaways for this discussion are you're paying particular attention to your pre-op evaluation. Do not assume anything. Do not take things for granted. Be very thorough and explain your findings to your patients. And that last part, if you know you're going to explain your findings to your patient, then of course you know that you have to be thorough and your examination has to be complete. So that ends my talk. Thank you again for listening, and stay safe, everyone.
Thank you for sharing with us your past cases, Dr. Bengson. It was a very insightful lecture on the things to take note of preoperatively, and hopefully I'll not forget before performing blepharoplasty, something I'll be sure to apply in my future practice.
Yes, I agree. Very interesting cases, sir. Now that our lectures have been given, I think we can answer the questions from our audience. Let me bring up our first question. Okay, our first question. Do you recommend using intralesional steroids for scars? What kind do you usually give and what concentration? When is the best time to give? I believe Dr. Pasco mentioned that she used steroids.
Yes, I
Or
do.
I think it was
Yeah,
or I
both
think
of us,
Dr.
Ray and
Lemon.
to. Go ahead.
Yeah, both.
Yeah, both.
Eman, ha?
Both, yeah.
Sige, I can answer the question
I
since
can do
parang
that too.
nabanggit siya in my lecture. Do I give steroids for scars? So actually, to be honest, in my practice, I am a little bit conservative in terms of treating these scars. So it depends really on the threshold of both the surgeon and the patient. So if the patient can actually be patient about it, I really believe that the body, especially if they don't have any predispositions to poor wound healing, the body can heal itself well. So especially in the periorbital area, it's very vascularized. So in time, these soft scar tissues actually improve. But if really needed, usually I wait around 2 months before I give. And then if I give, usually I would use, and I think this is commonly used by others as well, I use intralesional triamcinolone acetonide injections. We can use the 40 milligram per ml preparation around 0.0 ml per 1 centimeter, or it really depends on the size of the scar tissue. But you have to also be careful with using steroids because it doesn't come without side effects. So you have to explain to your patients that they may have some atrophy, especially if you inject it in fatty tissues. And you can also induce some hyperpigmentation or even telangiectasia. So I don't all the time immediately give it to them. So I explain first that sometimes you just have to really be patient. Like, for example, with Dr. Ali's case, it was a good example of how the body heals by itself without much invasive interventions. So also, my first line would usually be silicone gels. So actually, I find that very useful and non-invasive, very, very safe. Maybe the others can share their experience.
Yeah, I did mention using intralesional steroids. I would usually wait 6 weeks at least. I observe whether there are areas that are hard or there are scars that are not acceptable cosmetically. It also depends on the threshold of the patient. If the patient tends to be, kind of complaining about it, getting antsy. So you really have to do a lot of hand holding and at the same time explain their options because you're not going to push a treatment to them as is. So one of my go-to is actually intralesional steroids before. Well, now I still do a lot of that. Sometimes I give about zero point 0.1, I dilute it sometimes with either saline or sometimes even lidocaine because if they start experiencing the pain, they usually don't go back to you. As you can see from my cases, from the cases that I presented, medyo ano sila, turn off sila sa second dose. Kasi medyo masakit siya. Kasi imagine that's a scar. Scar siya na intralesionally you inject into. Tapos, I'm just careful not to inject not too superficially. And I usually would push the needle and then inject going out. First, for whatever it is. Parang ganun lang yung treatment or turo sa akin sa boss ko. So, that's how I do it pretty much. Dr. Ali?
Yeah, so I have used intralesional steroids a couple of occasions. In fact, and I used it on that patient while waiting for his wound to heal, hopefully preventing more contracture of the scar and worsening of the ectropion. In that particular case as well, it's very important. I forgot to mention earlier that as Nonet mentioned, the lids are supposed to protect the eye, main function. And when you have a case like that where you have an ectropion, obviously the lids aren't functioning as they should, and the eye is compromised. So you have to remember that you're treating the patient as a whole. So you have to protect the eye, the cornea, give a lot of lubricants. We instructed the patient as well to do a little lid massaging upward to sort of try and stretch it out. And a lot of hand holding as well and explaining. It's very important when you have these, when you see these things happen, to be more diligent in explaining to the patient what happened, and making sure you also let them know that there's a solution and it can be repaired, and there's a timing for it. There's a proper timing for it. A lot of times they just want it repaired as soon as possible, and that's not actually the ideal way to do it. So you just have to be really patient with them, and yeah, things will work out. Thanks.
Yeah, like for your first case, the first case you presented. Okay. So thank you for your answers. For the next question, what antibiotics or specific preparations would you recommend for trauma cases? Are empiric antibiotics warranted? I think this is directed to Dr. Pasco Rosete.
In terms of antibiotics, actually the coamoxiclav in itself, the good old reliable coamoxiclav works pretty well, even for dog bites, because the flora of the dog saliva daw tends to be addressed na by that alone. That, of course, you would also include your anti-rabies and your anti-tetanus. But for general trauma, if you debris pretty well, remove all the foreign body, do a meticulous closure, basically most infections can be prevented. The antibiotics would be very handy, as I said, the coamoxiclav, clindamycin probably if you really want to beef up a little bit. So if you're suspecting you're planning about MRSA and everything, so you can always put that. It doesn't have to be IV, oral is fine. Depending on the situation of your patient, of course. I'm talking about trauma patients.
Okay. So so all of the other consultants also use co-amoxiclav and clindamycin as well.
Usually,
All right.
yes.
Usually. Okay, so our next question. If the patient with ectropion develop corneal problems, how soon do you recommend a re-op?
Yeah, okay. So a patient ectropion has to be followed up quite regularly to really monitor the effect on the cornea. Um, Now, normally, the wound should heal within the next like month, right? The swelling should subside in about a month or two, and then you will see the final appearance, the final position of the lids, so to speak, and then you'll be able to determine how much of the laxity is there and how much you have to repair. How to determine that when there's still a bit of swelling. So I would say to hold off for at least 3 months. Okay? But if the cornea is starting to deteriorate and there's no other way to protect it, then you could do it a little bit earlier, as long as the swelling is gone and you're sure that the wounds have healed relatively completely already.
Do we have any other answers from our speakers, or we all agree? No? Okay, maybe we can move on.
Okay, so for the next question, for Dr. Benson, are there any pearls for lid crease forming sutures?
Okay. Yeah. So if you're creating a lid crease from nothing, because a lot of patients have these very light lid creases, and for those cases, I usually don't put any sutures internally anymore. Just removing the skin and using the laser to, and I learned this from my mentor, Dr. Vic Lopez, creates a lid crease in itself when you use the laser to sort of contract the tissue underneath the skin near the tarsal plate. But if you're doing a lid crease suture, forming a lid crease from nothing, there are several ways to do it, and I know some of our colleagues have, depending on where you train, have their own way of creating lid crease. Maybe they can share later on. But what works for me is I use Prolene 6.0 or 7.0 sutures, and I put the suture um, on the tarsal plate and subcutaneously on the lid crease incision. I put 3, again depending on how deep you want the lid crease or how prominent you want it. So I put 1 laterally, middle, and medial as well. Inverted mattress suture, so that the knots are away from the skin. I know there are other ways to do it, and I'd be interested also to find out what the other surgeons, how their technique is.
Yes. For me, for lid crease forming sutures, usually I also do the 3 sutures medially, laterally, and centrally. And I usually anchor the suture to the skin, orbicularis, and levator. And usually I use Vicryl 6.0. So I used to do buried sutures like Dr. Bengson, but sometimes I know that after a week, it peeks out through the skin. So I also sometimes try to do like I would also, the other option I would go for sometimes is to just place a suture, like a non-absorbing suture. So the concept is really you want fibrosis to set in, which will create that lid crease. Another one I have seen done before by my bosses in training, they just did 3 small incisions, medially, laterally, and centrally, like a strip. And then they take out a little bit of the orbicularis, and then they hinge to the tarsus superficially and then to the skin. So actually, it's very minimally invasive and less manipulation, and it actually also produces good results. But so far, I haven't tried that. Usually, open sky pa rin yung ginagawa.
Right. So it's sort of like similar to that when I do my lid crease sutures together with the blepharoplasty. But like Rian said, if you determine preoperatively that you're not going to remove any skin, and let's say in a young patient in their 20s or 30s, which we get more often now, there's no skin to be removed. So you can just do those 3 incisions, those small incisions. I usually anchor it like to the tarsus because the levator is quite high. So if you have a lid crease that's high, then yes, I might attach it to the levator. But like in Asian eyes where the lid crease is very low, like maybe 5 to 6 millimeters from the lash line, I just anchor it to the anterior tarsus plate.
Okay, so our next question, how would you select patients that you think would benefit from an internal brow pexy as part of a one-step process procedure?
Okay, so if we're talking about just simply the brow ptosis and not the actual upper eyelid ptosis, I usually come across these patients when they come in for a blepharoplasty. Nobody comes in and says my eyebrows are asymmetrical because most of the time they don't notice it, and most of the time I'm the one who points it out to them. They come in saying both eyes are droopy, but one eye seems to be more droopy, and then I point out that that's because the brow on that eye is lower, and that's why it seems you have more dermatopalacia in that eye. And then when I show them a mirror, they have that aha moment that, oh man, no, I never noticed that before. And then so I have to explain to them, well, we have to correct this because if we don't and we proceed with the blepharoplasty, it's not going to be symmetrical still, right? So they understand that. But whether it's going to be a brow pexy or a direct brow lift, it just depends on how big the difference is between left and right, or how low the brow is in relation to the orbital rim. If it's below the orbital rim, at or below the orbital rim, then I might actually do a direct brow lift, where you excise a flap of skin and muscle from above the brow. But if it's at or slightly above the orbital rim, you could get away with just a brow pexy, which avoids a scar on the upper brow, which Asian skin doesn't heal well from. Because the skin on the brow is a lot thicker and it could keloid and it could form a hypertrophic scar, as opposed to the skin on the upper lid or the lower lid, thinner. I hope that answers the question.
I think it does, yeah.
Okay, so for the next question, is there a role for lasers like what the dermatologists use in the treatment of eyelid scars? I think this is directed to Dr. Rian.
Okay. Yeah. So actually, like what I said, there's so many advancements in the field of wound healing. So treatment of scars with laser therapies are actually possible and they are viable options. But to be honest, I have no direct experience with it. So I would actually, if in case I would consider that, I'd ask for my dermatology friends to collaborate with me in terms of using that treatment method. But it is possible. If you look at literature, it's actually used to treat hypertrophic scars, especially those that are not that thick, because the laser treatments that we have nowadays are actually safer. So I think, like, for example, the fractionated lasers, it decreases the amount of laser beams that get that are used. So actually, it's more safer. But actually, the dermatology specialists have more experience with it. So if the patients request for it, I would probably just refer to them. I don't know with Dr. Bengson or Dr. Nanette, Dr. Nanette.
Same here, I think. For yung kaninang, the one that I showed, the pulse, the hyperemic scar, the hypertrophic scar, I tried researching on that. And on hindsight, I was thinking that I would have waited, di ba? So I said, I would have waited, baka the hyperemia would have resolved eventually. But as I said, I would have put more silicone sheets than go to laser directly. Silicone sheets immediately or even during recuperation and then after. And then, but for that one, specifically for the hyperemia, it usually resolves. But they said that pulse dye laser used by dermatologists works well with persistently hyperemic scars.
Yeah, there are some cases of eyelid surgery where the incisions are difficult to plan out, and it's tough to follow the facial lines. And sometimes you still get these scars or incision lines that are obvious. And the dermatologists are really good at managing these. In the cosmetic practice, I do refer some of the patients, especially those who, let's say, had an upper bleph and the incision necessarily had to extend laterally because the lateral droop was so severe. And it's difficult to conceal that in the natural face lines. So I've referred to dermas. They've used the pulse dye, and I've seen a lot of patients improve a lot from that management.
Okay, so I think we have two last questions. Second to the last, how do you appease patients who are unhappy with their results? Maybe we can
Everyone
get one.
can.
Yeah, everyone can answer this.
A lot of chair time, actually. A lot of chair time. Actually, preoperatively, if you already prepared your patient, basically, di na mahirap yung pag-explain afterwards. But then I talked about trauma patients and nobody anticipated that in the first place. So in the trauma, for my end, I explained that sometimes the reconstruction on the first part, it may not just be one primary reconstruction and everything would go well. Chances are there might be a second or even a third if need be. But I always emphasize that my first surgery would be to restore function and not cosmesis in itself. If still unhappy, then we try to remedy the cosmesis after. But I make sure that I tell them that we get a scar, but the most important, the priority then is to create functional scars, so that the physiology in itself of the eye is restored.
Siguro ako. With my practice hasn't been that long. Pero what I learned is to really level expectations. So apart from chair time, actually in part with chair time, you want to make sure that your goals are actually in line with what your patients expect. So at least from that onset, you agree on the same thing. Pero if they still are unhappy, wala ka na masyadong magagawa doon. Of course, you have to explain what you did and best care pa rin yung binigay mo. And then, hopefully, again, with talking to them, you explain to them. And also, you offer them other options. Like what Dr. Ali mentioned, there are always options that we can do to improve or get things better for them. So, yeah.
Yeah, I agree with both of you. I've learned that managing expectations is the first order of business. When patients come in with functional complaints, they're not too concerned about the cosmetic appearance. Some of them are still, conscious of it, but it's not a priority. But patients who come in for cosmetic reasons or aesthetic reasons, that's the priority. So the results have to meet their expectations. And you have to be wary of patients who come in and say, this is what I want. They bring in pictures and say, this is what I want, even if it's not possible to give them what they want. So that's where your skill in managing expectations and being frank with them and honest, saying that I can't do that for you. That's not what this surgery can do for you. Don't try to make promises that you can't fulfill. So that's one thing. If they have the wrong idea, then you have to correct it. If they have the wrong idea of what to expect from this particular surgery, then you have to correct it and explain why. It's not enough to say no, that can't be done. You have to say why it can't be done, because they'll leave your clinic saying hindi pala kaya ng doktor na to. You have to explain why hindi kaya. It's not the doctor, it's the procedure. It's not really meant for that, diba? So a lot of explaining. You have to have a thorough consent form. So I work for an organization that has had a lot of patients that were difficult. So naturally, they're very careful, and they have a very thorough consent form. But in addition to that, because a lot of patients really don't read that consent form, so they still have these ideas on their head, and it's really up to the surgeon to correct those false ideas. Once you've done that, you've done your job, then you can relax. And if something should come up, just go back to the explanation that you did before the surgery, and stick to the science of it. And just empathize, I guess. Show some empathy so that they know that you care about the results as much as they do.
Okay, thank you, sir. I think we have one last question.
We have one last question. What are your approaches for lateral hooding with involutional lateral hooding? I think this is for Dr. Bengton, or anyone can answer.
Yeah. So the last time I heard that term was from my fellowship. That was actually a term I think that was coined by Dr. Camara. So it might be a fellow Camara fellow who was asking that question. So yeah, there's a lot of drooping. A lot of patients have this involutional lateral entropion, which is a hooding of the skin over the lashes in the lateral aspect, which sort of pushes the skin downward, causes a lot of marginal erosions there. It's a discomfort for patients. And what I've noticed is a lot of these cases, aside from the dermatoplasia and the heaviness of the skin, maybe coupled with the brow ptosis, there's the lacrimal gland is also quite prominent. Sometimes when you open it up, you see part of the lacrimal gland protruding. So you have to be prepared for that. It's not just a simple bleph that will resolve that. Like I said, you have to assess as well the brow, the lateral brow, and be prepared for if and when you open it up. If you see part of the gland protruding, you might have to tighten up the septum to prevent more protrusion of the gland. So sometimes it helps to put a suture. I don't know if other surgeons do this, but if you notice like the soft tissue of the lateral aspect of the lid that's very lax, sometimes you can put a tightening suture, which is attaching the lateral tarsal plate, the superior border, and anchor it upward to the lateral orbital rim, superior lateral orbital rim. I don't do it that often. I've maybe done it like just a couple of times in the past 20 years. But that's something that you might want to consider if warranted.
Thank you for answering that question. So I think that's our last question, and that's all of our questions for today. It makes me really happy to see. I think all of us are happy to see how interested our audience is in our topic. I think all the topics are actually very applicable.
Yeah, I agree. So, as we end today's episode, we'd like to thank our speakers today, Dr. Parula, Dr. Pascal Rosete, Dr. Bengzan, and we'd like to thank everyone for joining us. We hope you learned as much as we did today.
Yeah, I surely
Thank
learned
you.
a lot. Yes,
Thank you.
surely learned
Thank
a
you
lot.
for having us.
Thank you for having us.
Shout out to the Wednesday group of American Idol. Bye, guys.
Good night. Good night, everyone.
Thank you.
So Evan and I hope to see you when we host again here on DMC ITV Ophthalmic Construction Without Borders. Good evening, everyone. See you again.
Evening. Bye.